Welcome to your online lecture for Chapter 17 entitled Psychological Emergencies and Crisis Intervention. In emergency care for physical problems, the cool thing is that you usually can see the wounds you are going to care for. You can assess them, you can dress them, you can bandage them, and often you get to see the positive results of your effort as a first responder. This is in contrast to a behavioral emergency or a psychological emergency that you might encounter in the field. Typically, you cannot easily see what is causing a patient's behavioral emergency. In addition to this, you may not be able to see your words comforting or your presence providing much care to a patient who is panicked and may be depressed. And so I think it's important for you to understand as a first responder that the care that you give to your patients in a behavioral emergency can save lives too, although it may not appear to be the case when you're in the midst of the emergency situation. So the purpose of this online lecture is just to talk about different psychological emergencies that you might encounter as a first responder. So before we can begin this lecture, I think it's important to start with a definition of what behavior means. And so when we think about behavior, we think of something that is defined as the manner in which a person acts or performs, right? And so we'd say that's normal behavior. How do they act? How do they perform? When we think about something that's a behavioral emergency, we have to define that a little bit differently. And so we would say that a behavioral emergency is a situation where a patient exhibits abnormal behavior, right? And so what's defined as abnormal behavior, right? We could say everyone is abnormal in some sense. When we think about abnormal, we're going to kind of define that even further, and we're going to say that abnormal behavior would be behavior that's going to be unacceptable or intolerable to not only the family, but the patient and or the community in which the patient lives. And so when we as first responders walk into the scene of a behavioral emergency, it is always best to consider all patients who exhibit unusual or bizarre behavior as having an altered mental status. Okay, so something that is a behavioral emergency, we would say that this patient is going to also be considered or grouped into a group of patients that have altered mental status. As a first responder, it's important for you to note that this patient can pose a danger to you as a first responder, to themselves, and to others if there are others at the scene. And so it's always important to survey the scene for safety first, to make sure that you are safe, and to remove all others from the scene so that they cannot be injured if this patient is violent. So when we think about behavioral emergencies, they can occur with medical, trauma, and psychiatric complaints. So I think a lot of times as first responder, we just assume that, okay, if there's a call and it's a psychiatric complaint, yes, this is a behavioral emergency. But when we think about something that's traumatic in nature, a traumatic injury, if there's lack of O2 to the blood, eventually that patient could, or to the brain, O2 to the brain, that patient could also become very violent or turn violent and have a behavioral emergency. So I think sometimes we underestimate the trauma in medical patients, and we tend to overestimate and assume that when it's a psychiatric case that it's going to be a behavioral emergency. 1, 2, 3 different situations could pose or could present with a behavioral emergency. So what we can say is that patients with behavioral emergencies may act in unusual and expected ways, right? We've defined that already. They can pose a danger to themselves through self-inflicted injuries, and or they could commit suicide, but they can also pose a danger to others through violence or actions that they might not be able to understand. And so as a first responder, it's important to keep the following basic principles in mind whenever you are at the scene of a behavioral emergency. The first one is to always identify yourself as a first responder or as a healthcare professional. By identifying yourself, you let the patient know that you are there to help them, right? Because if they don't know you, if the patient is unfamiliar with who you are, they might be threatened by you. So rule number 1 or step number 1 is always going to be to identify yourself, to state your level of training so that the patient knows who you are, that you are there to help them. Step number 2, we would say, is to try to keep the patient informed. And so what do I mean by that? What you want to do is you want to inform the patient of exactly what you are going to be doing if you are going to be doing anything. What we know about behavioral emergencies or patients who are exhibiting abnormal behavior is that uncertainty might make that patient more anxious and more fearful, and that kind of leads to increased chances of them becoming violent. And so again, we want to keep the patient informed if we can. The third step in this process is remaining calm. We really want to remain calm. And the reason we want to do that is because, again, if we are anxious, then the patient who is suffering from a behavioral emergency might see that and become more anxious. And that could also lead to violence. And then last, but definitely not least, and probably most important when we're encountering a patient who is suffering from a behavioral emergency, is the acknowledgement of the patient's feelings. And so we never want to say things like, I know exactly how you feel. But what you can do is use phrases like, I can see that you are very upset or very mad. I'm not surprised that you feel frightened. You can use statements that do not put you in the patient's situation or in the patient's shoes. And in fact, what they're saying is that when we tend to try to identify with the patient, that makes them more violent because they truly do believe that you don't know how they feel. And so when we think about our patients, we always want to make sure that we are listening to them, or we always want to show our patients that we are by rephrasing and repeating part of what they are saying. We can also do that by asking questions such as, I heard what you said. Now, can you kind of repeat that for me again? Or say things like, I see, can you keep going on and telling me how you feel? You're always continuing the conversation so that your patient knows that you are at least acknowledging how your patient feels. And this is a continuous process until advanced medical personnel arrives at the scene. So during your patient assessment, of course, after you've ensured that the scene is safe to enter, what you're going to do first and foremost is really consider the need for law enforcement during your scene size up and throughout the call, right? If you suspect that the patient is a threat to others or to himself, then arrange for backup law enforcement at the scene. And typically this is in the form of a police officer. And then we'll also talk about other guidelines that will help you in your patient assessment. The big deal to me is doing a thorough scene size up. You want to locate the patient before approaching, right? Sometimes we enter the scene of a behavioral emergency and we might not know where that patient is. So the first thing we need to do is locate the patient, figure out where they are before we actually approach the patient. The next thing that we want to do is we really want to look for any weapons or items that could be used as weapons, such as like a knife or a blunt object like let's say a pole or something, and we want to remove those from the scene so that our patient cannot use them to harm themselves or others. If the patient's family members are at the scene, or friends or bystanders are at the scene, what we want to do is ask the patient if they have a history of being aggressive, ask the people at the scene if they have a history of being aggressive and or combative, and then people at the scene can also help you find out if the patient has been violent or threatened or has threatened violence at the scene. And so we can really utilize the family members to kind of get a history or a background of the patient who is suffering from a behavioral emergency. I think one thing that goes unsaid and that I really want to warn you guys about is listening to the patient, and being ready to expect that violence may occur, right? Expect violence if your patient is yelling, if they're cursing, if they're arguing, or verbally threatening to hurt someone. And last but not least, signs of possible violence in a patient include moving towards you, right? Carrying a heavy object or threatening object, making quick or irregular movements. In those cases, if a patient kind of moves towards you in a violent manner, then again, you're going to exit the scene and then wait for advanced medical personnel or law enforcement to arrive before you enter the scene again. So how do we treat a patient who's suffering from a behavioral emergency? You kind of treat them the same way you would if it were a trauma patient or a medical patient, right? And so first things first is, while caring for a patient who has a behavioral emergency, really you want to comfort them. You really want to calm them and reassure the patient as much as you can. One rule of thumb is never to falsely reassure your patients, right? So you're never going to say everything's going to be okay, because that might not be the case. Another rule of thumb is never to leave the patient alone. And one of the reasons we never want to leave a patient alone is because they are at a high risk for suicide. And so it's your responsibility, once you've responded to a behavioral emergency, it's your responsibility to ensure your patient's safety. And that is a legal responsibility to you as a first responder. And so then last but not least, after we've calmed and reassured and we've kept an eye on the patient, we want to treat any medical conditions that you find in a behavioral emergent patient. You might find that they've caused harm to themselves, and so you might have to treat little wounds, nicks, and knacks, and care for them as you would a trauma or a medical patient. So So you as a first responder will figure out that situations presented by behaviorally disturbed patients are often very difficult, but there are some techniques that can kind of help you if you are placed in a situation where you have a behavioral emergency. And some of these methods are really just truly designed to try to calm your patient down. When you'll find that if you can calm your patient down, that everything else will flow succinctly and easily. So one thing that you're always going to do is acknowledge that the patient seems upset, and to restate that you are there to help. You always want to maintain a comfortable distance from the patient, so that if they do charge at you, it gives you enough room to move away from the patient and to exit the scene before they can catch you. A big rule of thumb is never threaten, challenge, belittle, or argue with disturbed patients. Remember that the patient is ill. So no matter what they say, their comments are never directed towards you personally. Never lie to your patient. Always tell them the truth. Always try to tell them or reassure them and reconfirm them and let them know what's going on. And if you have a patient who is having hallucinations, whether that be visual or auditory, never play along with that. Instead, just reassure the patient that they are temporary, and then can clear up with treatment. So you always want to be pushing treatment towards your patients with behavioral emergencies. Again, ask questions in a calm, reassuring voice, never in a voice that would sound as if it was condescending or accusatory in nature. And then last but not least, really just encourage your patient. I think if nothing else in a behavioral emergency, the role of the first responder is truly just to encourage your patient, to try to get them to tell you what is going on. Try to establish rapport and trust with your patient. You'll find in a behavioral emergency that this will go a long way. If you are faced with a situation where you have a violent patient who is either going to do harm to themselves and to others, or you as the first responder, we really have to think about the art of restraint, right? And so when we think about restraining the patient, it should be avoided unless the patient poses a danger to himself and to others. And restraining patients is a legal issue. So it may require police authorization in your EMS system. And so it requires you as a first responder to have an understanding of your state laws and regulations as it relates to patient restraints. If you are not authorized by your state law to use restraints, then you're going to wait for someone with higher or equal authority to do so. And so while you're waiting, just remove yourself from the scene. If you are authorized to use restraints, then you're going to work in conjunction with the police and other EMS providers to do this restraint. And so one type of restraint that you might use in conjunction with other EMS providers is here. You can see that we have 3 different first responders, 1, 2, and 3, who are all helping to restrain the patient. It's very rare that you should do a single person restraint, because you might get injured and the patient may overpower you depending on whether or not they're on some type of illicit substance. One thing with doing or performing a restraint is that if you are going to do it, you should always use reasonable force. Avoid using unreasonable force. You never want to inflict pain or any other unnecessary force while you're restraining a patient. That isn't the goal of a restraint. We think about a restraint and what it's used for. It really is used to help or to hinder the patient from injuring themselves. And so reasonable force, how would we define that? It refers to the amount of force needed to keep a patient from injuring himself or herself and or someone else. And so it's dependent on a few different variables, and then you can kind of see them listed here below, but the size and the strength of the patient, the type of abnormal patient or the type of abnormal behavior that the patient is exhibiting. And so you could say you would not expect to use the same kind of force against a frightened patient who is huddling quietly in the corner as you would against an angry patient who is loudly threatening to kill you. And so you have to use the amount of force necessary for each scenario. You also want to take into consideration the mental state of the patient, right? It may be reasonable to use more force on a patient who is loud and threatening than a patient who is quiet and subdued. And then the method of restraint that you are going to use should also be taken into consideration. Some people use like a soft leather or cloth straps, and these are called humane restraints, and they are generally considered reasonable. Metal cuffs, for example, would not be, or some type of rope would not be as well. And we can kind of see what would be within normal limits. And you can kind of see the patient getting strapped down here, where they're kind of using like a seatbelt restraint to restrain this particular patient in this particular scenario. All in all, what we would say is that the goal is to not restrain a patient. If we have to, we should only do so if the patient is posing harm or threat to themselves or the people around them. When restraining a patient, as I've said, you probably want to involve the EMS in this restraint. And the major reason is legal liability. When you have more responders helping you with the restraint, it protects you from a lawsuit. And here's why. You have more witnesses at the scene, more people to vouch for what it is that you did as a first responder. And so again, the rule of thumb is never to restrain a patient alone. You should always have a witness. If you are going to do a restraint, I think it goes without saying, but that restraint should always occur with the same gender. So if you are a male and you need to restrain a female, maybe you have a witness so that the female can't accuse you of, let's say, sexual assault later down the line. So always make sure there's a witness when you are going to do a restraint. It protects you from legal liability. So with behavioral emergencies, we do have to take into consideration legal considerations, right? If we are going to restrain a patient, there is a chance that we as a first responder could be sued. But here's the thing. Your legal problems are greatly reduced if an emotionally disturbed patient or a patient with a behavioral emergency consents to care. However, such patients commonly refuse treatment, right? And so in that case, we kind of get stuck in limbo. Do we treat the patient or do we not treat the patient? As always, identify yourself and ask, at least try to get consent to see if the patient will allow you to treat them. And if so, then you're in the clear. If not, then we have to figure out, well, morally, are we going to try to help this patient? Or legally, are we going to take a step back, call 911, and let advanced medical care help provide the adequate care for that patient? Generally, you may provide care against a patient's will only if the patient threatens to hurt him or herself or others, and only if you can demonstrate reason to believe that the patient's threats are actually real. So let me say that again. The only time that you can treat a patient who does not give consent in a behavioral emergency is if that person poses a threat to himself and or others. And the other thing is that you have to make sure that these threats seem real. If not, you could be held legally liable for assault and or battery because you touched a patient without their consent. So the two most common behavioral emergencies that you as a first responder might encounter in an emergency situation would be drug and alcohol related emergencies. And so we're going to talk about the two concepts separately so that you can get a greater understanding of what the patient might present like and how you as a first responder can care for this particular patient in an emergency situation. So as we talk about these two different behavioral emergencies, let's first just define drug abuse. And we think of drug abuse, it's the self-administration of one and or more drugs in a way that differs from approved medical or social practice, right? And so really with drug abuse and alcohol abuse, there are three different stages that the patient kind of can go through. And so the first one and the most common one is a drug or an alcohol overdose. And so we think overdose, this is an emergency that involves poisoning by either drugs, taking too much drugs, or drinking too much alcohol. On the opposite end of the overdose spectrum, you can also have a patient or encounter a patient who is going through a withdrawal phase. And this refers to the effects of the body that occur after a period of abstinence, either from the drug and or the alcohol, to which the body has become accustomed to, right? You can imagine that if you've been a drug user or an alcohol abuser for months and you just decide to either kick the bucket or remove that from your life, that the body is going to have some type of adverse effect. And that adverse effect is the process of withdrawal. And then we can imagine that in a patient who is going through withdrawal, or in a patient who may have overdosed on some type of drug or alcohol, that they might be combative in nature. And so what's this mean? It means that they are aggressive, that they are angry, and that they might pose a threat to a first responder. So we're going to talk about how to treat these patients and how to recognize the signs and symptoms of each of these steps. So when we think about drug overdoses, they typically involve drug abuse by longtime drug users. However, and this is obviously probably the number one cause for drug overdoses, However, I think it's also important to be thinking about the fact that a drug overdose can also be the result of like a miscalculation either on the patient's part or the physician's part, confusion, use of more than one drug. So if a patient is taking multiple drugs and they have some type of adverse side effect, and it could also be as a result of a patient who is trying to attempt suicide. So we think drug abuse, we not only need to be thinking about, or drug overdose, we not only need to be thinking about patients who have long-term drug use, but also patients who may really just have miscalculated their medication for the day, or patients who are actually trying to kill themselves in an attempt by taking too much of a drug or drinking too much alcohol. So some signs and symptoms that would indicate a life-threatening emergency due to a drug overdose or alcohol abuse could include, but not be limited to, the following list, which would be the patient who is unresponsive when you arrive to the scene, a patient who has airway problems, either the airway is closed off, they've had an adverse side effect, the patient might have an abnormal or irregular pulse when you assess that either at the carotid and or the radial pulse. They may have a fever, which is very interesting. So one of the adverse side effects in some particular drugs on the street is to increase core temperature, so that patient may feel warmer. Vomiting is another sign and symptom that isn't listed on this PowerPoint, but probably should be. So we would say the patient might vomit as a result to move this poison from the patient's body. And then last but not least, if the patient is unconscious, no oxygen going to the brain, it is highly likely and possible that your patient might seize. Now, if these signs and symptoms are present, so we're talking about this list right here, if these signs and symptoms are present, your patient is a high priority for transport, specifically if you suspect drug overdose or alcohol abuse. So we report to dispatch immediately, and then other additional signs and symptoms may also be present, but would vary widely, and they include a patient who has altered mental status, a person with extremely low and or high blood pressure. Other signs and symptoms would be like sweating, tremors, and even hallucinations, especially with your patients who are coming off of alcohol or are suffering from alcohol withdrawal. Your patients might have digestive problems, visual disturbances, they might be combative in nature, or they might be paranoid. And so that list of other signs and symptoms aren't as consistent. The list that you see on this particular PowerPoint slide is very consistent and really indicates an increased severity for your patient. We need to make sure that this patient is getting treatment right away. If your patient is unresponsive when you arrive to the scene and you suspect either a drug or an alcohol emergency, after the initial assessment of the patient, you want to do the following. So the first thing you want to do is put on gloves and then open the patient's mouth. And you want to check the patient's mouth for partially dissolved pills or tablets. If you find any, remove them so they cannot block the patient's airway. The next thing that you want to do is smell the patient's breath for traces of alcohol. Do not confuse the smell of alcohol with a musky, fruity smell, such as a patient who might have diabetes. And then last but not least, you want to ask the patient's friends, if they're there, or family members, what they know about the incident. And so you really want to get a thorough history from family members and or friends and bystanders. Like, let's say, for example, your patient was at a bar. You could ask the people at the bar, what happened, what did they see, etc. So if a patient is unresponsive, again, check the airway for pills, smell their breath for alcohol, and then last but not least, we want to survey the scene and ask anyone around if they know what happened. This will give you a better guide as a first responder to determine whether or not a call to 911 is warranted, and to determine how we are going to treat that patient if we need to treat them. So this is just a figure of the signs and symptoms that might be present in a suspected drug and or alcohol related emergency. So again, the number one sign would be unresponsiveness. And then if they're unresponsive, then they're probably going to have respiratory difficulties. Remember, if you are unresponsive, probably not breathing, decreased oxygen, it's going to lead to either a high or a low pulse rate, depending on what they took. They could vomit. Remember, the body's natural response to get a poison out of the body would be to excrete it. And one way to excrete it is to vomit. And then that patient might go into seizures. Remember, we talked about tonic phase and the clonic phase of seizing. So you would be able to judge, are they in the early stages of the seizure or the later stages? And now, based on last week's lecture, you should be able to treat a person who has seized. So how are we going to care for a patient or a victim with a drug or alcohol related emergency? Your immediate goals, honestly, are to protect yourself. And then after you've protected yourself, you want to maintain the patient's airway, make sure it's open, and manage any life-threatening conditions, right? If the patient has difficulty breathing, then one of the things that we could do is administer oxygen to increase the saturation of oxygen within the patient's body. We want to monitor their mental status and their vital signs. Again, your vital signs are going to be your A, B's, and C's, airway, breaths, and circulation. And then another big deal is if we have an unconscious patient or a patient who is either overdosed or in a drunken state, we want to maintain body temperature, right? We don't want that body temperature to drop too low, and we definitely don't want it to go up too high. And so as a first responder, what are we doing? What's the main goal? The main goal is to make sure they have an open airway, make sure they're getting enough oxygen, then make sure that they have a good mental status. And then another major goal would just be to prevent shock, right? Eventually that patient is going to come down from either their alcohol-induced state or their overdose. And so we want to make sure that we prevent shock when they do come down from their drug or alcohol-related emergency. One key thing in a drug and alcohol-related emergency that you want to prepare yourself for is vomiting. Remember, what did we say? We could put the patient into the recovery position, and the recovery position, regardless of if our patient is conscious or unconscious, will do what? Place the head in a gravity-dependent position and will facilitate the removal of vomit from our patient. So as a first responder, unfortunately, we may encounter emergency situations where we're dealing with either a victim of rape and or sexual assault. So when we think about rape and sexual assault, we could kind of say it's one of the most devastating crises that can occur in a person's life. Either way, we as first responders, we need to know how to care for these patients. We have to tread very lightly and not use any wrong term or speech that might set our patients off. We have to tread very delicately. So we're going to learn how to treat these patients if we encounter them in an emergency situation. When we're dealing with a patient who has been raped or sexually assaulted, we kind of have to treat two different aspects. We have to treat the emotional and the physical trauma. So when we think about rape and sexual assault, it isn't just the physical trauma that has occurred, it is emotional trauma as well. And so we would say that rape and sexual assault is a combined thing. It is both emotional and it involves physical trauma. And so we have to define both rape and sexual assault because they're actually two different things. And so when we talk about rape, what we would say is that rape would represent, we would say that rape is really defined as sexual intercourse that is performed without the consent of the person involved. And it typically involves some type of force, threat, and fraud where the person just feels completely threatened. But with rape, it's going to involve some sort of sexual intercourse. This is kind of opposite that of sexual assault. And so we'll define what sexual assault is so we can have a greater understanding of that as well. But it is defined as any touch that the victim did not initiate or agree to, and that is imposed by coercion, threat, deception, or physical or threats of physical violence. So we could see that with rape, there's definitely sexual intercourse involved, whereas with sexual assault, it's more of a touch. On any end of this spectrum, whether it be a victim of a rape emergency or a sexual assault emergency, we have to treat, again, the emotional and the physical traumas that are associated with that. And we have to be able to recognize a patient who has been subjected to such trauma. And so the best way to do that is with what is known as the rape trauma syndrome. And so an intensely personal experience under force or terrifying circumstances can destroy a person's inner defenses. And so just like a death where we go through the Kubler-Ross stages of grieving, a rape or sexual assault victim will go through what we call rape trauma syndrome. And rape trauma syndrome kind of involves 4 different steps, and these 4 different steps are listed below. But the first one is an acute reaction, which we'll talk about, and second is outward adjustment, third would be depression, and eventually years, maybe never, they reach what we would consider to be the acceptance and resolution stage of the illness. So with step 1, the acute reaction is going to be occurs immediately after the assault or the trauma, and typically your patient could present either very angry or very sad or very quiet, but it's that first reaction that the patient has to the trauma. With your outward adjustment, this typically happens weeks, maybe months after the initial trauma, and this is the person who changes their appearance, right? And so either you have a person who used to dress very promiscuous, now wears big, huge clothes to cover up their body, or vice versa. You have the person who was very conservative in their dress who is now wearing more promiscuous type of clothing. And so you have this outward adjustment where the person starts to basically change their appearance. And then third, we clearly depression is clear, and I don't think it needs any definition. And then eventually we would hope that our patient would get to a point to where they can accept and have resolution with the trauma that has occurred in their life. And so what step would we as first responders probably be most exposed to? And that step is step number 1, which is the acute reaction, because we're typically the first ones on the scene after the trauma has occurred. So what are we going to do once we're at the scene? The big deal truly in dealing with a rape patient or a sexual assault patient really is the immediate reaction that you have to the patient. Is probably one of the most important interactions that you could potentially have. The main thing is you never want to impose your own feelings. Instead, you want to try to find out what your patient's emotional state is. Remember, we're dealing with the emotional aspects of the trauma as well. And so not only do we have a trauma patient, but we also have a behavioral patient as well. And so some things that you can do as a first responder is, first of all, we're not allowed to let the patient take a shower, and this goes without saying, but taking a shower could wash away any evidence, and so we try to talk our patients out of doing this if we can. Another big thing is documentation. You need to note your documentation of the call to the 911 operator, and you keep these notes because they could later be used in court if we do find the patient's offender. And so your notes become a huge legal document of support for your patients. Going back up this list, you want to perform a patient assessment, and you can treat injuries if the patient will allow you to touch them. One thing is attempt to use a rescuer of the same gender. Rape victims and the sexual assault victims tend to be more comfortable with a first responder who is of the same sex. And so we want to perform our patient assessment again as a first responder, as you would for any other patient. Also check for trauma. When you're doing this, you're going to be looking, not touching, around the thighs, the abdomen, and the gluteal region if you can. And so this is, something that we typically don't deal with a lot on our campus, but it does happen all over the world. And I think as a first responder, this is kind of like a calling on your life where you could be placed in a situation where not only do we care for physical attributes of our patient, but also the emotional part. And when we have a rape and a sexual assault victim, the emotional part probably is the most important part to treat. Everything else can kind of go out the window for the time being. So in summary, when we're dealing with behavioral emergencies, whether that be drug-related, alcohol-related, rape, or sexual assault, the first thing we need to do is survey the scene. After we've surveyed the scene is safe, we need to consider the law enforcement that is needed when dealing with a behavioral patient. Typically, most behavioral patients, if they're not injured, will not require the EMS. They might require a police officer, a psychiatrist, or a psychologist, but very rarely will we send an ambulance to the scene of a true behavioral emergency if in fact they're not injured. You always want to stay on alert for signs of violence, and if there's violence, then we want to leave the scene until advanced medical care arrives. When restraining our patients, remember we only do it when it is absolutely necessary, and again we want to use reasonable force when we are going to restrain. Another thing is we want to make sure that when we're restraining our patients that we have witnesses, right? Again, always want to do a thorough scene size up. So in a drug overdose or an alcohol related type of emergency, we want to look for pills or clues that might give us a hint as to what the patient has taken and how much the patient has taken. And then last but not least, I think it's important for you as a first responder is just to make sure that you're stressing the importance of evaluation at the emergency department for rape victims. I think one of the biggest things or obstacles to treating rape victims and sexual assault victims is that they actually do not want to go to the emergency room and get the rape kit done. And so your job as a first responder in terms of caring for the emotional aspects is also to make sure that your rape victim or your sexual assault patient is going to get the care that they deserve. And part of that is actually going to the emergency department as soon as possible. If you developed a rapport with this particular patient, it might even be reasonable enough to go with them and to see them through the entire process until they are actually released. But that again is up to you. This is the end of your online lecture for Chapter 17 entitled Psychological Emergencies and Crisis Intervention. Please be prepared for your quiz, which is either online or in class. I hope you have a wonderful day.